We'll be continuing with the sessions. Whoever wants to have
go with the question. As the targeted audience are mostly first years of anesthesia department, I would ask them, are you familiar with the terminology inducing agents? How many of you are familiar? Can you raise the hand? The terminology inducing agent. Okay, good to know that at least 1/3 are familiar with this. And how many of you feel that the subject pharmacology is easy? Can raise your hands. I hope whatever the little knowledge you have is your second year pharmacology knowledge. So I assume that all of you feel that pharmacology is a difficult subject, but anesthetic pharmacology is all the more tough. So I have been assigned this task of a pharmacology topic. I'll try to make it as simple as possible. So before going into the topic proper, everybody should know what are the types of anesthesia. The anesthesia as such is divided into general anesthesia, regional anesthesia and local anesthesia. The definition of general anesthesia is that it's the process by which the patient is rendered unconscious in a reversible and controlled manner. So the components of this general anesthesia are unconsciousness, antinociception, amnesia and immobility, and maintaining a stability of the physiological system. The objective of general anesthesia is to minimize potentially deleterious effect and indirect effects, sustaining physiological hemostasis during surgical procedures and improving post-operative outcomes. So, induction and inducing agents. Before going into that, you should know the general anesthesia is divided into 3 phases, namely the induction phase, the maintenance phase and the emergence phase. What is induction phase? Induction phase is nothing but putting the patient to sleep and making him unconscious. This is the first step in general anesthesia. So inducing agents are those agents which are used to induce. So why do you want the patient to be unconscious? So the general anesthesia has various steps. The first step is unconsciousness, followed by, in general anesthesia, you may paralyze the patient and you should maintain the patient, and then the activity of all the agents should be reversed. So usually after induction we paralyze the patient. So before paralyzing the patient, you should always make him unconscious. So it is ethical that you make the patient unconscious before giving a muscle relaxant. If you just sedate the patient and give a muscle relaxant, it will be unethical because the patient will struggle like a fish out of water. This every first year patient should know, that should always induce the patient to sufficient depth so that then you can paralyze the patient. So this is the induction phase. The maintenance phase is you have to maintain an adequate depth of anesthesia throughout the surgical procedure by various agents, combination of agents. This is the next phase. The emergence phase is nothing but you are reversing the action of all the anesthetic agents and you awaken the patient. Coming to the classification of induction agents, it's classified into inhalation agents and intravenous agents. The first one is inhalation agents. Thanks to Pankaj Kundra sir for he has already clearly explained the physiology of inhalation anesthesia. So inhalation anesthesia or volatile anesthesia or the agents which are used to induce anesthesia by inhalation method. So these inhalation agents or volatile anesthetics are stored as liquids and they are delivered to patient as gases, and each and every individual inhalation agent is delivered by means of a specific vaporizer. So inhalation agents are delivered by a vaporizer attached to the anesthesia machine. Each and every agent will have a separate specific vaporizer. Coming to the classification of inhalation agents based on the mechanism of action, Agents which acts predominantly by GABA A and glycine potentiation are halothane and all fluorinated agents like N-fluorine, isoflurane, desflurane and sevoflurane. Agents which act predominantly by NMDA receptor inhibition is nitrous oxide, xenon and cyclopropane. These are the commonly used inhalation agents, but our area of interest is inhalation agents which are used for inhalational induction. So out of these agents, only 2 agents are used for inhalation induction. One is halothane, the other is sevoflurane. Coming to the pharmacodynamics of inhalation agent, the mechanism of action of inhalation agent is at 3 levels, namely spinal level, supraspinal and cellular level. At the spinal level, the inhalation agents cause immobility of the patient, whereas in the supraspinal level, it depresses the consciousness, it produces hypnosis and amnesia. That is, it depresses midbrain reticular formation and thalamus. Whereas in the spinal level, it inhibits both the spinal afferents as well as the efferents. At the cellular level, it blocks the postsynaptic excitatory glutamate and aspartate receptors. Pharmacokinetics has already been done by Pankaj Kutra sir. Just I will highlight the important points. Here in inhalational induction, the inhalational or volatile anesthetics is delivered to the patient by means of a gas, by mask induction. The inhalation agent is delivered to the patient by means of a mask into the lungs. So this is inhalational induction, right? So the absorption of inhalation agent into the alveoli, which is absorbed into the capillaries of the lung, which is distributed throughout the body, metabolized and eliminated again via the lungs. So you are giving the agent through lungs and it's eliminated through the lungs. This is inhalational induction. So for this to occur, as already said by sir, the alveoli will have a partial pressure of a particular agent which will equilibrate with the arterial partial pressure, and in turn it will equilibrate with the tissue partial pressure. So to attain a steady state concentration, not concentration, steady state of partial pressure. So alveoli, the blood and the brain all will be in equilibrium to achieve a induction. Is it clear? So alveolar partial pressure is the index for assessing the depth and recovery of anesthesia and also the potency, anesthesia potency. So the primary aim of inhalation induction is to achieve a continuous ideal partial pressure in the brain. For any inhalation induction, there should be an adequate partial pressure gradient. That is, there should be a gradient so that the gases will flow from one point to another. So you have 3 phases here. That is, first the gas, for example, you can take sevoflurane. It should come from the anesthesia machine, that is vaporizer, to the alveoli. Then from alveoli to arterial blood and the arterial blood to the brain. This partial pressure gradient is very important for good induction of anesthesia. The next determinant is the solubility and the partition coefficient. Already it has been dealt with. So the primary indicator of onset of anesthesia is blood gas partition coefficient. Blood gas partition coefficient is nothing but the distribution of inhalation agent, for example sevoflurane, between the gaseous phase and the liquid phase. That is gas and blood. So agents which have a high blood gas partition coefficient have a slower onset, because those inhalation agents which are dissolved more in the blood will have a slow onset of action. Pharmacodynamics, MAC has been already dealt very clearly by sir. So I want to stress only one thing. The MAC is inversely related with MAC, that is, higher the MAC value, lower is the potency of the drug. For example, you see the next point, you see methoxyflurane, it is 0.1 the MAC, whereas nitrous oxide is 104. But methoxyflurane is the most potent anesthetic, inhalation anesthetic. So the lower the MAC, higher is the potency. Coming to the halothane, now I am not going into much of the pharmacology. Halothane is an alkane with a MAC of 0.75 and a partition coefficient of 2.54. Halothane may cause a various action on the various actions on different systems of the body. For example, in cardiovascular system, it may cause a minimal decrease in the heart rate and moderate decrease in the mean arterial pressure. There's no change in the SVR. Its main action is by causing a myocardial depression and thereby decreasing the cardiac output. In respiratory system, it causes a moderate decrease in the tidal volume and a moderate increase in the respiratory rate. In central nervous system, it causes increased in the cerebral blood flow and ICP. The most important side effects of halothane is hepatotoxicity. Two types of hepatotoxicity. The one is important is immunogenic hepatitis. The next agent used for induction is sevoflurane. It is an ether with a MAC of 1.8 and a high potency with a blood gas partition coefficient of 0.69. It's the commonly used agent for inhalation induction, especially in pediatric age group, fastest acting. The actions are, it doesn't have any change in the heart rate, minimal decrease in the mean arterial pressure, systemic vascular resistance and cardiac output. In respiratory system, it increases the tidal volume, mild increase in the respiratory rate, there is no change in the pulmonary vascular resistance. Again, all volatile anesthetics will increase the cerebral blood flow and it will also increase the ICP. The toxic compound formed by using sevoflurane is compound A in fluorides, which is nephrotoxic. So, halothane is hepatotoxic, sevoflurane is nephrotoxic. So, it's contraindicated in liver failure, this is contraindicated in renal failure. Coming to the method of inhalation induction. So, you have seen all the pharmacology. So, how do you induce the patient or how do you make the patient unconscious with the gas? You know, by giving an agent into the IV intravenous system, you know how it acts. But here, how you are going to perform the inhalation induction. Usually we place the mask over the face of the patient and first we pre-oxygenate with 100% oxygen for 3 minutes. Then we can give a mixture of oxygen to nitrous oxide as a 50-50% mixture. Then if you are going to induce with halothane, you increase the concentration of halothane gradually till you reach the desired effect. Likewise, sevoflurane also. So, gradually increase the vapor concentration through respective vaporizer. For halothane, you start with 0.5% and the maximum of 5% you can reach. And for sevoflurane, you start with 1% and a maximum of 7 to 8%. There are many techniques of inhalation induction which I am not going to elaborate. The adverse effects. What are the adverse effects that can occur during this inhalation induction? The patient may cough, there may be excitatory movements, there may be breath holding, laryngospasm, vomiting, rigidity and shivering. You should be very cautious while administering this inhalation induction. Then how do you know that the correct endpoint is reached so that you can intubate this patient with the inhalation induction? So the common signs we use is the eyeball fixation, the hypotonia of the limbs, marked hypotonia of the limbs and jaw relaxation, very important. So if you see the jaw, whether it's relaxed or not, that will give a clue that your adequate depth of anesthesia is reached. So that is with inhalation agents, halothane and sevoflurane for inducing anesthesia. Coming to the intravenous agents, we have thiopentone, ketamine, propofol, etomidate and in rare cases midazolam. These are the key drugs which are used as induction agents. The classification is based on the mechanism of action. Agents which act predominantly by promoting the GABA and the channel-mediated chloride influx. They are the barbiturates group, benzodiazepine, alkyl phenols and imidazole derivatives. In the barbiturates, thiopentone is the only drug we are using right now, and imidazole derivative is etomidate, alkyl phenol is propofol, and last but not the least is midazolam. The agents which block the influx of cations via the NMDA receptor is ketamine. Unlike inhalation agent where MAC is the indicator of potency, in the potency of IV agents is determined by the free plasma concentration of the drug, which we will not be able to measure because it's very difficult to measure. So there is a clinical endpoint cannot be monitored unlike a inhalation agent. So free plasma concentration of the drug at equilibrium that produces loss of response in 50% of the patient. What happens when you deliver a drug into the intravenous system? When you give a short bolus drug, the calculated dose is used as an induction agent. When you give a short IV bolus, there is a short period of unconsciousness with rapid onset, followed by rapid recovery of the patient. We will see how this happens. You recollect the physiology, there are three compartments. One is the vessel-rich group, which receives 75% of the cardiac output, the brain, heart and kidney. The muscle group, which is the major group, 50%, but receives only 18% of the cardiac output, and the fat group, which receives 5.4% of the cardiac output. Whenever IV bolus is injected, for example thiopentone, it equilibrates with the vessel-rich group and produces loss of consciousness. When the peak is reached, then the plasma concentration will decline. So what will happen is, the drug which is in the brain will redistribute from the brain to other tissues. The concentration in the brain will decrease, and that will result in a recovery of the patient. So the initial recovery of the patient following an IV induction is redistribution. But the irreversible removal of the drug from the body is by means of metabolism and elimination. What are the factors that influence this bolus induction? One is the lean body weight, the cardiac output, the dose of the drug and the injection rate, and the most important is the fraction of the free unbound non-ionized drug. This is the most important one, which determines the induction, and the fraction of the unbound unionized fraction will determine the action. Titration to effect. As I have said earlier, for inhalation induction, how will you know that the patient has been induced sufficiently to proceed with the next step? So there are a lot of methods for each agent. Commonly, we'll ask the patient to count. As soon as the patient starts counting, or if there is no response to verbal command, then signs like loss of eyelash reflex or loss of manual grip, these roughly we take it as an index of sufficient induction. The tool to measure the depth of anesthesia is, when the patient is not responding to your surgical pain stimulus, it means it is the end point. So indirect measure of the depth of anesthesia. This is the most important part of the talk, because what is the effect of induction? That is the anesthetic implication. Hemodynamics, there is always, when you induce, there is a decrease in the mean arterial pressure and systolic BP. There is a loss of baroreceptor control, and there is a decrease in the sympathetic tone. All these put together will cause a hypotension or fall in the BP. So during induction, you should be careful to see, monitor and watch for hypotension. So how can we prevent this? Hydrate the patient adequately before taking up the patient. Watch the monitor for hypotension. If hypotension occurs, immediately you correct with fluids. Respiratory system. In the respiratory system, the induction agents will reduce or eliminate both the ventilated drive as well as the ventilated drive to hypoxia and hypercapnia. So you should be very cautious in maintaining the airway of the patient during induction. Whenever in the process of induction, the upper airway patency will be lost because of relaxation, and there may be airway obstruction and causing hypoxia. So you should be very careful during induction. The significance is, you maintain the patency of the airway by manipulating the head neck to maintain a patent airway. So gag reflex is lost, and the stimulus to the cough is also lost. In the GIT, during induction, the lower esophageal sphincter tone is reduced, and this may pose a risk of passive and active regurgitation in all GA cases, even in fasted cases. So in non-fasted cases, you should be all the more careful to prevent aspiration during induction. Thiopentone sodium is a barbiturate, as you know, with a pH of 7.6 and a sodium salt preparation of pH of more than 10. It has a rapid onset and offset. It's highly protein bound, no analgesic effect, but it may cause hyperalgesia. Laryngeal and tracheal reflexes are not very much depressed with thiopentone, and excitatory movement, coughing, hiccup and hypertonus may occur. Induction dose is 3 to 4 milligram. The adverse effects is garlic and onion taste, hyperalgesia and local tissue irritation. It is contraindicated in shock, bronchial asthma and acute intermittent porphyria. Propofol is an alkyl phenol which is milky white. It's an intralipid with 1% solution as 10% soya bean, 2 to 2.5% glycerol, 1.2% purified egg phosphatide with a pH of 7. Propofol has the propensity to decrease the BP to about 15 to 25%. It decreases its tidal volume, but in bronchus it causes bronchodilation. All IV agents may produce apnea. The dose of propofol is 1 to 2.5 mg per kg and the recovery is about 8 to 12 minutes. The important side effects is pain on injection. There may be a myoclonus, allergy to soya bean, and green urine may occur due to the presence of phenols. It is contraindicated in shock and allergy. The onset of action is 1.5 minutes. The elimination half-life is 4 to 7 hours. Ketamine is unique in the induction agent because it produces dissociative anesthesia. Dissociative anesthesia is nothing but the state of anesthesia resembles a cataleptic state in which the eyes remain open with a slow nystagmic gaze. Ketamine also produces rapid anesthesia and rapid offset, but the difference is it preserves the cardiac function and autonomic reflexes, unlike other agents. Peak plasma concentration occurs within 1 minute after ketamine IV and 5 minutes after IM injection. It is the induction agent of choice in acute hypovolemic patient, that is patient in shock or patient in hypotension. Ketamine is the induction of choice. The only limiting factor is emergence delirium produced by ketamine. So the caution is it is a myocardial depressant if endogenous catecholamine stores are depleted and sympathetic nervous system compensatory response are impaired. So if the patient has an impaired sympathetic system, this ketamine is contraindicated. The dose is 1 to 2 mg per kg. Onset is 30 to 60 seconds. And return of consciousness is 10 to 20 minutes. But full orientation after ketamine may take 60 to 90 minutes. IM induction is a route which is used only in children with ketamine in the dose of 4 to 8 mg per kg. The onset is very fast, it's about 2 to 4 minutes, can be used in pediatric age group. The two important side effects I want to quote with ketamine is, one is ketamine inhibits platelet aggregation and the other one is emergence delirium. Etomidate, it's a carboxylated imidazole. It is a unique because it is a single isomer. It has also rapid onset and offset. It is the induction agent of choice for elderly patient because it produces the hemodynamic stability is achieved with etomidate. The duration of action of etomidate is increased by the increase in the dose or if the drug is given as a continuous infusion. The dose is 0.2 to 0.4 milligram. The onset of unconsciousness occur within 1 arm brain circulation. Side effects of etomidate is myoclonus. So this can be prevented by giving opioid like fentanyl 1 to 2 microgram per kg IV or a benzodiazepines. The next important side effect of etomidate is adrenocortical suppression, which may occur even with 1 dose, and it may last up to 4 to 8 hours. It is due to the inhibition of 11 beta hydroxylase enzyme. Midazolam is very rarely used for induction of anesthesia. So what are the ideal properties of inducing agent? It should be soluble in water with good stability. It should not cause tissue damage, venous irritation or pain. Hypnotic action should be smooth. It should not produce serious 2 minutes. It should not produce serious or RS depression. It should be free from any drug interaction. and nil or minimal potential to cause histamine release and hypersensitivity reaction. So, is there any drug available at present? No drug is available which will adhere to all this. So, you titrate all the drugs according to the patient and to the patient for the safety. So, the take-home message is select an induction agent based on the comorbidities and clinical condition of the patient in need of anesthesia. The anesthetist should be well aware of the pharmacokinetic and pharmacodynamic properties of selecting the right drug. The choice of induction agent is specific for each patient. Careful monitoring and titration of anesthetic agents are crucial to maintain a safe and effective anesthetic state. Thank you. I thank Professor Edward Johnson sir for giving me this opportunity. Thank you.
Thank you, madam. It's a very vast subject, so you have tried to complete it. As we are running out of time, I would hand over to Dr. Paulraj sir to introduce the next speaker.